Welcome to the Explainer, medical students. You know that moment of panic on the wards? You put your stethoscope to a chest and it just sounds like a washing machine of ambiguous noise, right? Well, today, we are turning auscultation from some mystical, subjective art into straight-up applied physics. We're going to decode all that noise into a crystal-clear clinical signal. Here is our roadmap for today. We've got tools of the trade, the primary sounds, decoding S2 splits, the extra sounds, and finally, essential clinical maneuvers.
All right, let's jump right into Section 1, Tools of the Trade.
Before you even touch the patient, you've got a choice to make. Heart sounds are just brief, discrete auditory vibrations. They're defined by frequency, or pitch in hertz, and intensity, which is loudness in decibels. So you have to pick the right chest piece. The diaphragm is your go-to for high-frequency sounds, somewhere in the 120 to 150 hertz range. Think of those soft musical or blowing murmurs that happen when there's a really wide pressure difference between chambers. But the bell? That's what you need for low-frequency sounds caused by low pressure differences. So here's the crucial takeaway. Flip to that bell when you're hunting for low-pressure pathologies. We're talking about those rough, rumbling, or thud-like noises. If you feel a palpable thrill on the chest wall or you're suspecting an S3 and S4, a murmur like mitral stenosis, or, rare as it is, a tumor plop, the bell is absolutely your best friend. Moving on to Section 2, the primary sounds. Let's look at S1 and S2 mechanics. This is our foundation, right? The classic lubbed-up you has every single time you listen to a heart. S1, the lub, marks the start of systole. It's just the sudden tensing of those AV valve leaflets. And its intensity is incredibly diagnostic. A super loud S1, that strongly suggests tachycardia, or maybe mitral stenosis, where the valves are snapping shut from a distance at high speed. A soft S1, though, might point to poor ventricular contractility. Then we have S2, the DUP. This marks semilunar valve closure and the start of diastole. But its mechanics, they're actually a bit more complex. Now, this is a fascinating concept, the hangout interval. See, valves do not shut the exact millisecond chamber pressures change. S2 is generated right at the crossover pressure, when the vessel pressure exceeds the relaxing ventricular pressure. But there's a tiny lag between that crossover and the physical valve snapping shut. That little lag is your hangout interval. And here's why that interval actually matters clinically. The aorta has way higher pressure and much lower distensibility than the pulmonary artery. Since it's stiffer and highly pressurized, the aortic valve, A2, snaps shut really fast, with a hangout interval of just 30 milliseconds. But the pulmonary artery is way more distensible, so it has a longer, 80 millisecond lag. That is the exact physiological reason why A2 normally happens before P2. Okay, Section 3, decoding S2 splits, normal versus pathological. Since we know why A2 precedes P2, let's deconstruct the notoriously tricky S2 split. Think about the normal physiological sequence. When your patient takes a big breath in, that inspiration literally sucks more venous blood back into the right side of the heart. That extra volume takes the right ventricle longer to eject, right? So it stretches out the time it takes for the pulmonary valve to finally close. That gap between A2 and P2 widens to over 50 milliseconds, making the split totally obvious to your ear. That's a normal physiological split. You will absolutely want to memorize this because identifying pathological splits is a classic high-yield board takeaway. A wide split that hangs around during expiration, that could mean a right bundle branch block or mitral regurgitation. A fixed split, meaning it doesn't change one bit with respiration, is the classic hallmark of an atrial septal defect. And a reverse or paradoxical split, where P2 actually fires before A2 and you hear it during expiration, that tells you aortic closure is significantly delayed, pointing straight to a left bundle branch block or aortic stenosis. Now, what if you never hear a split at all, no matter where they are in the respiratory cycle? Well, then you've got a single S2. This is a massive clinical clue. Sure, it happens naturally as we age, but it's also a major red flag for severe pulmonary arterial hypertension. Or it could mean one semilunar valve is simply absent or totally diseased, like in valvular atresia. Let's roll into Section 4, the extra sounds, the intruders in the cardiac cycle. With the primary sounds and S2 under our belts, it's time to spot the intruders. Any extra sounds that pop up in this super tight window right after S2 are classified as early diastolic sounds. Think about the timeline. S2 closes at 0 milliseconds. Right after that, we hit protodiastole, followed by the period of isovolumetric relaxation. Grouping these early diastolic sounds by timing
really helps you isolate them before you even start analyzing their pitch. Hear a high-pitched sound immediately after S2? That's an opening snap from an AV valve. Does the sound get louder when they breathe in? Suspect a pericardial knock. And if it's a low-pitched sound, you might actually be hearing a tumor plop, which is strongly tied to an atrial myxoma.
You've got to watch out for systolic clicks, though. These happen when the semilunar valves open, which you'll see in things like a bicuspid aortic valve or mitral valve prolapse. Because of their timing, they're super easy to confuse with a loud S1, but they mean wildly different things for your patient's valve health, so pay close attention. Is it truly at the very start of systole, or is it just a slightly delayed click? Which brings us to the famous gallop rhythms. An S3 ventricular gallop is a low-pitched thud. It's caused by rapid ventricular filling smacking into the wall right in the middle of diastole. On the other hand, the S4 atrial gallop happens late in diastole. This is literally the sound of the atria squeezing hard against a stiff, non-compliant ventricle during atrial systole. Finally, Section 5, Essential Clinical Maneuvers. Unmasking hidden sounds. We know what these normal and pathological sounds mean now, but how do we actively hunt them down at the bedside? That's the million-dollar clinical question, right? If a sound is too soft or totally drowned out by annoying hospital noise, we don't just give up. We play detective. We actively change the patient's physiological parameters to force those hidden sounds out of hiding. The easiest tool you have is the patient's own breathing. Asking them to exhale and hold it amplifies pulmonary ejection clicks and really helps unmask an S4. On the flip side, having them take a deep breath in boosts that right-sided filling we talked about, which pumps up the intensity of P2 and makes pericardial knocks way easier to catch. The big secret here is dynamically moving your patient. Suspect an opening snap? Have them stand up. Hunting for that tricky low-pitched S3 gallop? Roll them onto their left side. That left lateral decubitus position brings the apex of the heart right up against the chest wall. Still nothing? Do a passive leg raise. Lifting their legs dumps a flood of venous return right into the heart, practically forcing a faint S3 to show itself. So, as we've seen in this explainer, clinical auscultation is a highly active investigation. It is definitely not just passive listening. You are actively manipulating physiology with breathing, positioning, and augmentation to force the heart to spill its secrets. To pull it all together, you are essentially using your stethoscope to measure physical pressure differentials in decibels and hertz, mapping those sounds onto a precise millisecond timeline, and testing mechanical limits in real time by seeing how they react to your maneuvers. With these acoustic rules in your toolkit, the days of just hearing a random jumble of noise are officially over. Get out onto the wards, apply the physics, use your bell and diaphragm correctly, and start turning that cardiac noise into life-saving clinical signal. What hidden diagnoses are waiting for you on your very next rounds?